Welcome back, y'all. Today, we are going to get right into it, y'all. We are going to talk about one of my very favorite things in the whole wide world, which is the foot and the pelvic floor connection. I'm so pumped, and let's get into it. I hope you enjoyed the first episode of From the Ground Up, where I discussed how taking a no Kegels approach built a weightless brand. And if you missed it, make sure you pop back and listen, because I'm telling you guys a lot about how I got this whole thing called Genesis off the ground and running. And truly the biggest points that you guys need to know to scale your practice and build a brand that people care about and want to join. So I believe that so many of our patients, and just people in general, suffer from chronic pelvic floor dysfunction, leaking, prolapse, or only are seeing partial or temporary results from going to pelvic floor therapy because we as clinicians tend to overlook the foundational role of foot mechanics in the kinetic chain, and frankly, how that impacts the pelvic floor's ability to function. Okay, so literally, it's everything. It's everything. And if you're missing this point, if you are missing how the foot connects to the pelvic floor muscles, you're missing probably everything. And this is probably the reason that your patients are not getting fully better, or they get better for 6 months and then their leaking comes back in the gym. This is going to be very impactful for you in your practice, and I'm very excited to teach you about this. Let's start actually up at the pelvis. I know, I said the foot, but we got to understand how the pelvic floor works and how the pelvis biomechanics work before we kind of work our way down the chain to put it all together in the big picture. When we're looking at the pelvis, we have, our ilium bones. And in order for the pelvic floor muscles to do their job, which in this case, let's think about them lifting, let's think about them squeezing, clamping off the urethra, basically doing everything to support the pelvic organs and keep things like pee inside our patients' bodies. So in order for the pelvic floor to do that, to be able to ascend and clamp off the urethra and keep things where they need to be, the ilium bones have got to be able to go into an internal rotation. If you guys can picture your pelvis, you want to think about your ilium bones rotating forward, rotating internally. And what that's going to do at the outlet of the pelvis is it's actually going to open it. It's going to widen it. That's exactly where the pelvic floor muscles connect. So if you're picturing the bottom of the pelvis at the pelvic outlet, when the ilium bones go into internal rotation, the pelvic floor muscles, they actually get lengthened, and then they can kind of act like a trampoline and kind of like boing, reascend back up into the pelvis. And that is that kind of pressure management that we are going to be striving for when it comes to things like leaking, pelvic organ prolapse, chronic pelvic pain and tension. We have to make sure the pelvic floor muscles can lengthen eccentrically and then reascend back up into the pelvis, because that's what's going to give this pressure lift the bladder, and allow the anterior pelvic floor to really clamp off the urethra and keep pee in. In order to do that, the iliums have to be able to internally rotate, y'all. If that makes sense, if you're following me there, we're going to kind of zoom out and look at the kinetic chain as a whole, because this is where we're going to really get into where the foot plays into all of this, okay? When we start to work our way out of the pelvis, away from the iliums, we're going to go from the ground up, okay? So we're going to be looking at, does the foot have the ability to go into pronation? Specifically, when I'm talking about pronation, I'm talking about the midfoot and its ability to kind of drop down towards the ground, but in a controlled, eccentric manner. Okay, that's going to be the key, because I know you guys are all thinking about, you have your patients in your brain where you're like, well, what about my over-pronators? And what about my people who just collapse into pronation? And I'm here to tell you that pronation is necessary. First of all, we have to be able to have the range of motion to get our foot to go into pronation. But just like every other joint in our entire body, that pronation has to be able to be a controlled range of motion. So your patients who you're picturing in your heads that, have a flat foot, or they just collapse right into that internal rotation and that pronation of the midfoot, that is what we have to train, this eccentric control in the foot whenever they're doing functional movement patterns. So when we're looking at internal rotation throughout the kinetic chain, it always has to start at the midfoot, you guys. And so one test that I really like, and I want you to put on your PT school student hats here. We're going to go back to PT school for a second, and we're going to think about the navicular drop test. I use this one often in my clinical practice, and I'm going to describe it to you guys so that way you can A, remember it, but B, you can kind of picture it as I talk through it and think about, I know you have your one patient in mind where you're like, yeah, but this girl is an overpronator. I want you to be thinking about her, and I want you to be picturing as I describe this test how you can assess her in this way with this navicular drop test. What's funny is the navicular drop test requires an official measurement. I'm going to be honest with you guys right now. I am not taking out a ruler. I am not measuring the drop of the navicular, but I am just using I'm kind of just eyeballing it, to be honest. And that's quicker anyways, and it's more functional when we're in the clinic. So all you're going to do is you're going to have your patient stand, and you are going to help them find kind of that subtalar neutral. So I put my hands on her ankle, and I kind of help shift the ankle over, and I'll give her some cues, maybe, okay, weight shift a little more over to your right, or whichever way I need her to weight shift to kind of see that subtalar joint, find that neutral position, and I'll help her get there. And once she's there, I will take note. So I'll visually look at the navicular tuberosity and kind of where that is on that medial aspect of the foot. And then I'll just say, okay, now I want you to just relax down to how you would normally stand. And then what you're looking at is that navicular bone. How much did it drop? Hence the name, navicular drop test. Okay. So you're going to look at this, and then there's some norms. This is where those fancy measurements come in. And honestly, again, I'm not whipping out my ruler and measuring these things. But if it's more than, say, 5 to 10 millimeters in your estimation, that's telling us that there is a quote excessive amount of midfoot pronation going on. The podiatrist down the street or your textbook might say, ooh, if we have quote too much pronation, then we need to throw an orthotic in there, and we need to control that pronation so that way they're not falling into the pronation. This is where I, raise my hand and I say, well, what if instead of just putting a rigid orthotic or a rigid shoe on this patient, what if we actually just train the muscles to control that pronation eccentrically? And then that way, in functional movement patterns, when they're going on a walk, when they're doing their workouts, when they're picking up their kid, whatever it is that they're doing, the muscles are now doing their job. And let me explain why, because we don't actually want to put a rigid orthotic in there and block the foot's ability to pronate because of everything I'm about to describe in the kinetic chain aspect of things. So it's really, really important that we check, do they have the pronation range of motion? And you can use that navicular drop test, because if you do the test and the navicular is not moving at all, then you're thinking, okay, they don't have range of motion. They're not going into pronation at all. So that's a good starting point, because you can decide, do I need to start on finding range of motion with her in her midfoot, or does she already have it, but it's just not being controlled? And once you do that test and you kind of see what's happening there, then that will help drive your initial treatment approach. Let's put this all together in the kinetic chain picture, because this is where it really gets fun. If you remember back whenever we talked about the ilium needs internal rotation for the pelvic floor muscles to be able to lengthen and reascend, to clamp off the urethra, and to hold up the pelvic organs and keep our patients from leaking, from having pressure symptoms, all of those things. The ilium cannot do that if the midfoot does not have adequate pronation range of motion and control of that pronation range of motion. So it starts there. It literally starts from the ground up. That's why I'm going to drive this point home to make sure you don't miss it, because you can look at things like the knee, and you can look at things even like dorsiflexion of the ankle, which I'm going to get into in a second. But if you haven't gone all the way down to the ground and assessed and made sure that the foot's doing its job, none of it's going to matter when your patient walks out of your clinic anyway. Okay. So we've checked the ilium. We've made sure that we have internal rotation there. We've checked the midfoot. We've used our fancy navicular drop test. We've made sure maybe they do have the pronation range of motion. Maybe they don't. We're kind of starting to formulate a treatment hypothesis here. This is why we start at the foot. Let me explain the kinetic chain aspect to you here. When the midfoot goes into its pronation, that is going to be coupled with some ankle dorsiflexion. Okay. So we're going to talk about the ankle here in a second, but just hear me out on this big picture for a second. So midfoot pronation, it couples itself with ankle dorsiflexion. And then as we keep working our way up the leg or up the kinetic chain, that's going to kind of cascade into this set of events, which then we'll see the tibia relative to the femur above it. Okay, so the tibia is going to start kind of going into this internal rotation. Then we keep working our way up the femur. We're going to see some femoral internal rotation kind of as we go into that mid stance, as we go into that weight bearing, which by the way happens with every single step we take all day long. And then above the femur, guess what we get to? We get to the ilium. And that's what will unlock, quote unquote, the ilium's ability to internally rotate. Alrighty, so there's kind of like big picture. We have to have the ilium to be able to internally rotate to allow the pelvic floor to work. And if the midfoot is not pronating adequately with every step we take, with every weight that we pick up in the gym, whatever, with every run we go on, the ilium is never going to get its chance to fully go into internal rotation because of that kinetic chain. So let me repeat it back to you, because I know if this is the first time you're hearing it, or even if it's the 100th time you're hearing it, I know I'm always like, wait, okay, say that again. From the ground up, we have midfoot goes into pronation. Then we're also going to get kind of the tibia, the screw home mechanism where it starts to internally rotate. And then above that, we start to have some controlled femoral internal rotation with that. And then above that, then now the ilium has space to be able to go into this internal rotation. And then when the ilium goes into this internal rotation, the pelvic floor gets to go boing, and it gets to bounce back up. It's almost like a trampoline that was, you're jumping on it and everything stretches down, and it has all of this like eccentric length and stored power. And then it gets to just jump back up, boing back up. You don't get the reascension. You don't get the trampoline lifting back up if you don't have ilium internal rotation. And you won't have ilium internal rotation if you don't have midfoot pronation. Okay, so that is huge. This concept, frankly, has changed my life. And whenever I figured it out in the early days of Genesis, I want to tell you guys this patient story. This was kind of the pivotal moment of my clinical career of how I treat the pelvic floor and looking at the foot. One of my very first patients, a few months into being the founder of Genesis, treating pelvic floor conditions, everything, she was seeing me for leaking when she was running. She had some prolapse symptoms. She had some leaking. It was funny because she would say, whether I'm picking up a weight or whether I'm reading bedtime stories to my kids and I'm doing the silly voices. And when you do the silly voices, you raise your voice, or maybe there's a scream in the book or something. And she would leak then too. So it was kind of both this like pressure management / also when her foot's hitting the ground and she's on her run. Okay. And so we had done kind of your stereotypical, bridges. I taught her how to breathe. We were working on pelvic floor coordination, like all of these things that we learn to be doing for our stress incontinence patients is everything that we had done. And we had probably done 4 or 5 sessions at this point. And she was like, well, I feel like I've seen maybe like 10% improvement. I'm still leaking when I run. I'm still leaking whenever I lift weights. I'm still leaking when I read bedtime stories, but maybe it's 10% better. And so I'm like, well, dang, like that is not good enough. 10% better. We want 110% better. And luckily, I was still in my program, my women's health certificate program at the time. And I had just had a lecture from an adjunct professor who was explaining the biomechanics of the foot and how it connects up at the pelvis, right? Basically, a lot of the stuff I just told you guys. And I was like, you know what, Melissa, my patient's name is Melissa. She's given me permission to share this, by the way. I was like, let's try something. Hear me out. I'm going to look at your feet. She's like, I'm all for it. Let's do it. And so I had her do some of the tests that I had learned in this class. I immediately saw a difference from right side to left side. On her right side, when I had her doing step ups on a stool, she was going up with the right, down with the left. Okay. So you can imagine I'm picturing how she steps up with her right foot and then lowers down eccentrically with that right leg, right, to touch the left foot to the ground. I'm like, oh my gosh, like your knee is pushing out and the arch of your foot is not budging. Okay. And so those were kind of some of the things that I had been taught to look at, was like whenever they go into this step up and they lean into it and they go into kind of that mid stance, you should see the arch of the foot kind of like lengthen, expand, and absorb those forces that are being pushed into the body as someone steps up on the stool. Her left was great. Her left was great. Her right was like a brick. I was explaining this to her and she's like, yeah, I rolled this right ankle a lot in high school playing soccer and never fully rehabbed it. It was just like a light bulb moment because I still didn't fully grasp the complexity of all of this and this connection, but I took what I knew at the time and I gave her some of the foot exercises and I did some manual therapy to her foot and her ankle and I sent her on her way. And that's all we did that day was I assessed her foot and I did the manual therapy to her foot and ankle and I gave her some foot exercises to do that day and at home. She literally came back. It was probably a week or two later for her next appointment. And I was like, hey, how's it going? Like, how are the foot exercises? Do you think I'm crazy? And she's like, actually, things are like 60% better. Nothing had improved this much in anything else that we had done with like the pelvic floor engagement and bridge exercises and hip strengthening and core strengthening. Like nothing had really made a dent until you gave me these 3 foot exercises. And she was talking about her running specifically. And she was like, I went probably 3 miles before I felt like I was going to start leaking. And then I was able to go the full 5 miles that day and just like had some leaking through the end of the run, but it started way later in the run. And then once it started leaking, it was way less that was coming out. And she was just like mind blown. And frankly, I was too. And I didn't do a very good job of hiding it at the time. I was just like, oh my gosh, this is crazy. We're on to something. And that was the moment that I was like, there is freaking something here. I'm not exactly sure what I did, but I did something with the foot that I learned in this one course that I took, and it seems to be working. From there, with this same patient, we kept hitting the foot. I kept digging deeper in the research and took some other courses and things. And as we went along with her care, she ended up being able to run 100% leak free. And then something else that was cool was that her leaking that she had complained about when she was reading with her kids, which by the way, doesn't have anything to do with her foot because, well, in the moment, because she's sitting in the bed, right? And you might be thinking, why did working on her foot change when she leaks, when she's like doing like yelling in a story, reading to her kids at night? And it's because the rest of the day where she's not sitting in bed, she's up on her feet, she's walking around. And so because we had worked on her right foot, we had worked to gain foot and ankle range of motion, and not only gained range of motion, we trained this control of the range of motion through functional patterns with walking, running, lifting, jumping, all of those things. Over time, over the weeks, that was able to allow her pelvic floor to gain length. That allowed, in those moments in the bedtime stories, that allowed her to not leak in those moments simply because we had changed her functional movement patterns from the ground up. As she went about her day-to-day life, that was allowing her pelvic floor to gain the length that it had been missing the whole time, which translated into even moments when she was sitting. And it all comes back for this particular patient and literally hundreds of other people I have worked with. It all comes back to making sure their mid feet, both feet have pronation range of motion, that they can go into it, but also that they can control that range of motion. And again, I'm going to repeat the kinetic chain to you guys because this is so paramount. Because what I want you guys to be thinking about is, yes, it starts from the ground up. And let's say you're assessing a foot and you're like, well, Becky, they have range of motion. They are controlling it. Okay, great. So you cleared the midfoot. You're going to start working your way up the chain. Now you're going to look at the ankle. Then you're going to look at the tibia. Then you're going to look at the femur, internal rotation, and ultimately the ilium. But I want you guys to be thinking, instead of always only starting, well, the pelvic floor is tight. It doesn't have length. Let me give her lengthening exercises for the pelvic floor. I want you to be thinking about why. Why is the pelvic floor staying tight? And why are these breathing exercises or these stretches not creating lasting change in the length of the pelvic floor? And I want you, instead of to always only starting at the pelvis and the pelvic floor, I want you to zoom out and I want you to start from the ground up. And I want you to be thinking, let's clear the midfoot first. If you get everything else up the chain to where it has adequate range of motion and control of that range of motion, but you haven't fixed the midfoot, none of it's going to matter because you're not going to get this nice cascade of internal rotation. Midfoot pronation is where we're going to start. You're going to have midfoot pronation that's coupled with ankle dorsiflexion. Then that's going to go up the chain and cause this cascade of tibial internal rotation. And then from there, that's going to allow the femur to gain a little bit more internal rotation as well. And then finally, we land at the ilium, which because the femur gains some internal rotation, now the ilium has room to gain this internal rotation. And the internal rotation of the ilium is what ultimately allows the pelvic floor to gain length and to reascend, just like that trampoline that we're picturing boinging back up, for lack of a better term, boing. That is the kinetic chain. That is the connection, biomechanically speaking, of the foot and the pelvic floor from the ground up. And that is why your patients with chronic pelvic floor tension, with leaking whenever they run, laugh, jump, lift, read bedtime stories to their kids, you have to figure out the why behind the pelvic floor tension. And it very well could be a midfoot that is stiff and not moving into pronation, or a midfoot that has pronation range of motion, but we are not getting controlled eccentric range of motion of the midfoot. Alrighty, so the kinetic chain is literally everything, and it has to start from the ground up. Just to drive it home, this is the main point from a pelvic floor perspective, is only treating the tension symptoms or the weakness symptoms is missing the root cause of pelvic floor dysfunction. And in this case, for our purposes today, that root cause could be the foot. If you take one thing away from today, it's that you have to zoom out of the pelvis, whether they're presenting with weakness, whether they're presenting with chronic tension. You have to zoom out to figure out the why. And you have to start from the ground up, and you have to make sure that their midfoot can go into pronation and can do it in a controlled manner. Because if we're only looking at the pelvic floor muscles, and if we're not addressing them from the ground up, we very well could be missing the thing that would unlock our patient's pelvises essentially and help them overcome their symptoms for good, help them return to running without leaking for good, not just while they're in your care, because we all have those patients that are doing better whenever they're with us, and then they ended up calling us 6 months later because everything came back. It very well could be the foot. So start at the foot, look at the kinetic chain from the ground up, and if the patient has adequate midfoot range of motion, and if they can control that range of motion in a functional pattern, in a functional way, their chances of having an ilium that can rotate internally and thus a pelvic floor that can ascend and support their bladder and clamp off their urethra is like much, much higher. If you guys found this interesting and helpful, I have an entire free guide called From the Ground Up, and it is going to go into more details. I'm actually going to give you my favorite manual therapy technique and my favorite midfoot exercise for your patients, and you can get that in the show notes here. And I also would love it if you would take a screenshot of this episode and share it to your Instagram stories. Tag me. I would love to see it. I would love to hear what you guys think. Thanks so much for listening. Go back to your very next patient you have today or tomorrow, whenever it is that you're seeing her, and look at her foot and then message me with what you find. And I guarantee you it's going to blow your mind. It's going to blow her mind, and it's going to change the game.